Hi, this is Elizabeth Hecht, and my talk is entitled CTA and MRA for the Abdominal Radiologist. I have nothing to disclose, and these are the objectives of my talk. So most importantly, don't forget to look at the vasculature. This should be part of your routine check of imaging, whether it be CTA, MRA, or conventional CT or MR of the abdomen and pelvis. Look for secondary signs of vascular compromise, such as ischemia. It's important to look and using multiplane reformats and any other 3D tools that can help better measure the vessels, as well as look into the lumen of the vessels and assess for stenosis, for example. Sometimes you can really work with what you have and make a diagnosis, but you have to know your limitations and when dedicated CTA and MRA are necessary. A standard lexicon and a grading system is crucial for communication. For example, at our institution, at the bottom of all our angiogram reports, we have a definition of what we mean by mild, moderate, and severe, and my radiology colleagues all use a similar lexicon. In this talk, we're going to really approach vascular disease using a pattern-based approach. We're going to talk about variants, narrowing, dilatation, filling defects, ulceration, leaks, and tangles. I've broken it down to common patterns that we see, and this should help. If you can recognize these patterns, then you can narrow your differential. So, very importantly, variants come into play not just for liver donors and renal donors, but also for pre-treatment planning. The more we do endovascular therapies, the more these variants come into play. So beginning with liver donors, as we know, the demand outweighs the supply, and so we're dealing with a lot of living donor potential candidates. And in order to determine if someone is an appropriate candidate, the important factors that we consider are the volume of the liver, to know that there's sufficient volume to enable the recipient to have function or sufficient function for their body habitus. You also want to look at the anatomy, the bile ducts, hepatic artery, portal, and hepatic veins, as well as incidental findings. And we're trying to determine, one, whether the patient is a candidate at all, let alone whether they should approach the right or left lobe for a donation. Now, a lot of it comes down to volume, but the anatomy has a very important role to play. The most important challenges to recognize are the more anastomoses, the more risk for complications. So multiplicity is the most common thing that we'll encounter. Also, if there's any crossover between right and left lobe, this has implications and vessels may be sacrificed or the patient may not be a good candidate. Also, any unusual course of the vessels where there's a crossing or entanglement of vessels, this may be very challenging to deal with, and again, this may be a contraindication to donation. When we're thinking about liver donors and treatment, we really want to think in segments, not just right lobe versus left lobe. For example, segment 4, supply maybe from the right hepatic artery, left hepatic artery, or both. So it's really important to distinguish what you mean by right hepatic artery or left hepatic artery. It can be very ambiguous. The terms such as accessory can be ambiguous unless you really are clear on how many arteries there are and what segment they supply. So here's just examples of multiplicity. We have a patient on the left who has 2 right renal arteries, one arising from the celiac and proper hepatic artery in a more conventional pattern, and an accessory, an additional right renal artery, which arises from the SMA. In this other patient, we have 2 left hepatic arteries. The segment 4 arises from the right hepatic artery, and that's not so unusual, but the segment 2-3 arises from the left gastric artery rather than the proper hepatic. So these are both important to recognize. In terms of crossover, it's somewhat unusual, but in this case, for example, the left hepatic artery supplies a portion of the right lobe, specifically segment 8 of the right lobe receives supply from the left hepatic artery, making it very difficult to consider splitting this liver into right and left. Segment 4, in this case, arises from the right hepatic artery. And while that is not unusual, notice how deep within the liver that segment 4 emerges from, and this makes it kind of more difficult for the surgeon's dissection, whether it be a right or a left lobe approach. Here we have an unusual case where the hepatic artery encases the bile duct, and this can be very dangerous as the bile duct may be injured in the process of harvesting and dissecting the right hepatic artery. In terms of portal venous anatomy, there are 3 general variants that we see. There are some other rare variants, but these are the most common. And again, if you have potential for more than one anastomosis, you put the donor at increased risk, which is the last thing we'd like to do. So in a trifurcation situation, it may be fine because you can really, because there's a trifurcation, you can potentially make this right portal vein into a single anastomosis. Whereas if you have this sort of branching pattern, where in this case, the posterior branch of the right portal vein arises early off the main portal vein, and so you see their separation from two branches which make up the supply to the right hepatic lobe. If those branches are far apart, it will require two anastomoses. If they're close together, then potentially they can be put into one anastomosis. But this sort of separation between branches makes it more challenging for the surgeon. Now, accessory hepatic veins, we will see not uncommonly, if they are large enough, they will be reanastomosed into the recipient to prevent congestion. It's important to note not only the size, but also the location, how much below the confluence the accessory hepatic artery is, so that the surgeon understands how to dissect to get to it. Segment 8 and 5 may drain into the middle hepatic vein, and so this should be noted. Again, the size of the vessel will impact whether there is going to be a reanastomosis required. For renal donors, we often take the left kidney. The number and location of renal arteries and veins are also important, just like they are in the liver donors. The more vessels, the more anastomoses, and the more risk to the donor. If there's any duplication of the collecting system, this should be noted, and kidney volumes and function are also important components to the decision making. In 25% of patients, there are multiple renal arteries. They can arise from any level of the aorta, as well as the common iliac artery. So it's important to, when we're planning on our protocol, to include the common iliac arteries. Veins, again, also can drain to the IVC or common iliac veins. And so you need enough coverage on your venous imaging to recognize that. And again, there can be multiple and there can be variants within. Here's some common variants that we see, such as a circumaortic left renal vein, a duplication of the IVC. And another thing to note is when there is a large lumbar vein draining into the left renal vein, this can, if not seen in advance, it can lead to a lot of bleeding, particularly in the laparoscopic approach. So you want to make sure that you recognize this and note the caliber of the lumbar vein for the surgeon. So venous variants not only can affect the potential renal donors, it also can impact IVC filter placement and surgical planning for procedures such as aortic repair. Now, malignancy can spread through invasion into the venous system, and if there are variants, then malignancy may spread in more unusual patterns. Here's just some example of again, some arterial variants with multiple left renal arteries, early branching right renal arteries. This is a CTA, and this is a non-contrast MRA, just to show you that this can be done with various techniques, depending on the preference of the institution. And just to note, arterial variants can also impact endovascular stent graft planning and positioning. So here's an example of a patient with an infrarenal endograft, and if you'll notice, the left kidney has signs of ischemia in the lower pole. If you notice here, there's actually an accessory left hepatic artery, which is actually occluded by the endograft, and this is leading to some ischemia. There may be some collateral supply, but part of the kidney is compromised because of the endograft. Now, just to note, this may be intentional, as the aneurysm needs to be repaired and the small accessory renal arteries may be sacrificed, but it's important to know this in advance so that they can plan accordingly and weigh the risks and benefits. Now, variants also are important for pre-treatment planning for procedures such as chemoembolization. So for our interventional colleagues, it's important to help guide them in their treatment planning. So here's an example of a patient with variant anatomy and several hepatocellular carcinomas. they have lesions in segment 8 and a lesion in segment 8, sort of partially also in segment 4. So in this case, you'll notice that there are two vessels coming off the aorta, and actually the first vessel is not the celiac, but it is the left gastric artery, and that left gastric artery is supplying the left lobe, as you can see, segments 2, 3, and 4 branches, whereas the other artery is actually a common mesenteric trunk. It supplies both SMA and celiac branches. So the right artery is supplied by that common mesenteric trunk. This is important to note, as one of the lesions may cross between right and left lobes, and so the interventionalist will need to know how to access the lesion to best advantage. Pancreas cancer staging also is very important, and to do so you really need to understand the vasculature, any variants, and to be able to observe vascular involvement. So this is just an example of a pancreatic body tail tumor that involves the splenic artery where there's circumferential involvement. Now, oftentimes that's not really a problem, and you just do a distal pancreatectomy and you can get a negative margin. However, in this case, the tumor has infiltrated even further and is involving the celiac artery, and therefore the patient may not be an immediate candidate and probably undergo chemotherapy. However, what's interesting to note in this patient, they also have a replaced right hepatic artery, meaning the right hepatic artery is arising from the SMA. That means that a lot of the liver is still supplied by this right hepatic artery. So if the patient responds to chemotherapy, they can be considered for something called an Appleby procedure, which is when they remove the celiac trunk, knowing that there will be sufficient supply by the hepatic artery arising from the SMA. So these are important things to note. Also, in addition to that, the left gastric artery is supplying the left hepatic lobe, incidentally. Just to note, like if you ever see a vessel coursing through the fissure of the ligamentum venosus, that is a really good sign that you have an accessory or replaced left hepatic artery arising from the left gastric. Occasionally, there can be veins running through this region, but most commonly, this is exactly where an aberrant left or a variant left hepatic artery courses through. Here's a patient where we are staging the pancreas cancer and the celiac artery is free of tumor. And so you wonder whether it could be resectable. However, this patient also has a right hepatic artery rising from the SMA. And in this case, the tumor is encasing the right hepatic artery near its origin off the SMA, and therefore the patient is not a surgical candidate at this time. Here's a patient with another pancreas cancer, more posteriorly located, and happens to be abutting a right renal artery. This is a bit more unusual, but this is important to note for the surgeon so that they don't injure the right kidney. And fortunately, this was able to be removed with a clear margin. There are some variants within the venous anatomy. This is a more unusual variant when there's absence of the portal vein, and instead there is an extrahepatic portocaval shunt. There's incidental variant of the hepatic and splenic artery in this case, with absence of the celiac and separate branching, but that's not as relevant. The more important thing is to recognize the absence of the main portal vein and this shunting, and this actually has implications. So if you recognize this, there's high risk for the patient to have additional risks, including developing liver lesions such as focal nodular hyperplasia and HCC, as well as developing hepatic encephalopathy leading to hepatic pulmonary syndrome. And so this is very important prognostic, has very important prognostic information in this variant. We'll move on now to narrowing, and it really comes in two flavors, intrinsic and extrinsic narrowing. Break it down into those that are intrinsic, like atherosclerosis and vasculitis that can cause luminal narrowing, mass effect from extrinsic compression due to masses, collections, or retroperitoneal fibrosis, for example. So here's another pre-operative or pre-TACE patient who has a hepatocellular carcinoma in segment 4. Now, what's interesting in this case, and it's a bit complicated, is the patient has a lot of atherosclerosis, and if you notice, the celiac origin is not visualized, but the branches are. In this case, you'll also notice a lot of pancreatic adenoidal collaterals. What's happening in this case is that there is occlusive disease at the origin of the celiac, and the SMA is actually supplying the branches of the celiac artery via the pancreatic adenoidal collaterals, or arcade. Some of those collaterals actually even have aneurysmal dilatation due to the high flow. So in this case, it's going to be impossible to access the hepatic artery, the right hepatic artery, and the left hepatic artery, which are both arising from the celiac, from the conventional approach. Instead, to get there, the interventionalists will need to go through the SMA and through collaterals to get to branches of the hepatic artery. And although this seems extremely challenging and ambitious, the interventionists were able to use their guide wire and get into branches of the left hepatic artery to re-embolize that segment 4 lesion. So knowing this in advance is very important to determine whether they're even going to attempt this procedure. Another potential cause of luminal narrowing is the intimal tear. We have a false and true lumen that develop, and the true lumen is often compressed by the false lumen, and this could lead to ischemia as well, particularly if the flap is dynamically occluding a branch vessel. So again, important to recognize dissection is also a potential cause of luminal narrowing. In this case, we have a dissection extending into the right hepatic artery, and this is also causing luminal narrowing. In this case, you don't really see asymmetry and enhancement, fortunately, but 8% of patients with aortic dissections will also have ischemic renal complications. So again, remember to look at the intimal flap and whether it affects branch vessels as well. Here we have a spontaneous SMA dissection with some thrombus in the false lumen and compression of the true lumen. It's very important to note whether there is flow in the false lumen or true lumen, and single arterial phase imaging may not be sufficient to determine that, and delayed imaging can tell you whether the false lumen is occluded or not. And this has implications in terms of prognosis. Other causes of narrowing includes vasculitis, the vasculitis. The ones that we'll more commonly see as abdominal images are those that affect the renal and mesenteric vessels, such as Takayasu, POLYARTERITIS, NODOSA. And often a biopsy will be required for diagnosis. And this is an example of a patient with irregular soft tissue surrounding the aorta and left renal artery. There are areas of narrowing and some areas of dilatation, and this is a patient with Takayasu arteritis. There's various vasculitis, and they're classified based on the vessels that they involve, whether large vessels or small vessels. There are mimics to vasculitis that aren't going to be, where immunosuppression is not going to be effective, and those include fibromuscular dysplasia and segmental arterial medial lysis. So it's important to distinguish what is really a rheumatologic disease versus a different type of disease process, because therapy will be different in those two populations. So in this case, we first notice that there is actually a wedge-shaped area of decreased enhancement in the spleen, suggesting ischemia. And if we look closely, we see in more detail that there appears to be a narrowing of the splenic artery. And if you look at you go back to the celiac artery, you can see there's soft tissue around the celiac, hepatic, and splenic arteries causing luminal narrowing. We see on an MRA done later that the celiac artery is absent. We can't even see it anymore on the MR, and there's also sort of this areas of narrowing within the SMA. And this, in this case, this is another vasculitis, and this is an example of polyarteritis nodosa. This is a median vessel vasculitis that affects older patients and is considered necrotizing vasculitis, with most commonly involving the kidneys. Again, microaneurysms and occlusive disease may also be a consequence of this arteritis. Here's an 81-year-old female with abdominal pain and weight loss, and again we see beading appearance of the celiac, SMA, and renal arteries. This disease process also can affect the carotids, and this is actually FMD and is not vasculitis in this case. As I alluded to, grading of stenosis is very important. You need the source data, and you really can't depend on reformatted images because you can over or underestimate stenosis. We really base our narrowing estimation on the NASIC criteria. And for smaller vessels, if it's difficult to determine whether there's a mild or moderate stenosis, we may just keep it simple and say whether there's less than or greater than 50% stenosis. You want to describe whether stenosis is focal or a long segment of stenosis, and you want to measure the length of stenosis or occlusive disease so that they can better determine the therapy. And this is how we define our mild, moderate, and severe stenoses at our institution. This is what's at the bottom of our report, so our clinicians understand what we're conveying in our reports. Again, look at the source data, but just to get a sense of things, this is what was considered a mild stenosis, moderate stenosis, severe stenosis, and actually a focal occlusion. I know it's an occlusion because collaterals are present. Now, as I mentioned, there are tricky things about interpreting stenosis, and there are various things that we can do to manipulate the images and kind of lead us down the wrong path. So here's an example just to show you how the window leveling on this MRA can certainly lead to overestimation of stenosis, as well as MIP imaging, making us really think that there is severe stenosis in the left inferior renal artery when it's only moderate in degree. Also on CT, window level is very important. We may think that the in this case, the aorta is widely patent, but if we use bone windows, we can see that there's an extensive calcified plaque within this aorta. This can be particularly deceptive in smaller vessels like the common iliac. So again, always really play with the window level to best see the lumen of the vessel, and this patient had more severe stenosis than expected. They also had really extensive calcific atherosclerosis with the entire aorta casted with calcium, sometimes referred to as the coral reef aorta. This is just important to note how the plane of imaging may help you better visualize stenosis. So, coronal plane may not be sufficient if the stenosis in the AP dimension. So it's just an example where it doesn't really look like there's much stenosis here in the right renal artery, maybe mild, but then when we oblique the images and really look more in the axial view, we can see that there's actually more stenosis than expected. So again, even though I don't completely rely on these images, it does just demonstrate in this case how important it is that to understand that stenoses may occur in various different ways, and just looking at one single plane is insufficient to make the diagnosis, and really want to go down the barrel of the vessel and really understand what the degree of stenosis is. There can be artifacts due to technique. If you use a voxel size that is non-isotropic, or a large voxel size and you're dealing with small vessels, then you're going to get the stair-step artifact and overestimate disease, such as in this case it looks like FMD involving the renals and internal iliacs, but here's the corresponding angiogram and it's totally normal. So you're going to kind of go down that route if you don't have sufficient resolution. Here's a potential renal donor using MR, and we see that there's lack of visualization of the external iliac arteries. In this case, we go to our source data, and we can see that there's sort of this blooming effect on bilaterally in the region of the adnexa, and this patient had undergone a tubal ligation with surgical clips that were causing artifact and mimicking stenoses. Extrinsic compression is another potential manifestation, or another potential cause of vascular narrowing. Again, we have the example of the pancreas tumor, which tends to encase the vessels and involve the surrounding vessels. And in this case, there's circumferential involvement and severe luminal narrowing of the celiac and its branches. This not only can be tumor, but extrinsic collection, such as this post-Whipple collection, causing narrowing of the portal vein. Now, extrinsic compression can also be kind of helpful and hint towards the diagnosis. In this case, the patient was post-Whipple and there was some soft tissue around the SMA. It was very recent post-Whipple, so we thought, could this be just post-operative change? They thought they got a good resection. 3 months later, you see that the soft tissue is increased, but actually more significantly, you see the luminal irregularity, which in this case is due to and really confirms the tumoral extension and tumoral recurrence in this region, unfortunately, for this patient. Other disease processes can cause extrinsic compression, things that we don't see uncommonly, such as lymphoma. Here we have less commonly retroperitoneal fibrosis can also cause vascular narrowing. Here's a patient who was a potential liver donor, and initially you see that there's collaterals, which is quite unusual. And when you look at the lateral images, you see, or sagittal images, you see that there is narrowing of the celiac. In this case, I think it is a true finding and not pseudostenosis, and this is a median arcuate ligament compression. Now, this is accentuated at end expiration, and we can see this in various patients, but in this case, the patient, although asymptomatic, had collaterals, which suggests this is hemodynamically significant. Other compressive syndromes include left renal vein compression, where the SMA sort of compresses the left renal vein. This can lead to collateral formation, hematuria, abdominal pain, and venous insufficiency. MAY-THURNER is another compression syndrome when the right common iliac artery compresses the left common iliac vein, causing stasis. And in this case, example, there's susceptibility to thrombosis, and here the patient has thrombosis. So they usually present with unilateral leg edema. Again, this can be seen, this compressive phenomenon can be seen in a lot of patients, and most are asymptomatic, but it can also predispose patients to DVT and leg swelling. So now we move on to dilatation. Now there's post-stenotic dilatation, where the actual important thing to recognize is that this is coming after a stenosis. So it's really the luminal narrowing that's relevant here. So dilatation may actually indicate there's a stenosis more proximally. Or we may be dealing with pseudoaneurysms due to trauma or infection, or an aneurysm, more commonly due to atherosclerosis and sometimes due to vasculitis. You want to really consider what the threshold is for calling an aneurysm. If you're not sure, it's certainly, either way, it's very important just to report the diameter, and you want to again go down, use double oblique imaging to get a true luminal diameter and not rely upon axial imaging for this. So you really want to be at the cross section of the vessel to better measure the aneurysms or the vascular caliber. And so these are just some concept of how aneurysms are defined. The visceral branch is more unusual to have isolated aneurysm. In this case, we have a common hepatic artery aneurysm, and intervention may occur when it's greater than or equal to 2 centimeters. So it's important to know when this becomes very important. Either way, it's when intervention is required, but either way, it's important to just document the size and to follow the size. Here's an example of a patient who has what looks like irregular margins and dilatation of the aorta. There's delayed enhancing soft tissue around the aorta or at the level of the IMA. The patient also has some underlying atherosclerosis. You can see there's also some wedge-shaped areas of decreased enhancement within the kidneys bilaterally. There's symptoms of fever. As we go farther down to the right common iliac, we see very irregular margins of the right common iliac, dilatation, and actually outpouching within the right common iliac. And this is an example of actually mycotic aneurysms with pseudoaneurysm formation. And essentially that is due to the infection. This infectious arteritis leads to really loss of integrity of the wall of the aorta, and really what we're looking at is a contained rupture. And again, this is very important to recognize because of the high morbidity and mortality, but in this case, oftentimes the patient will have symptoms of fever and septic symptoms, and you'll be able to put those connections together. This is a non-contrast imaging case. The patient has pancreatitis, and there is this hyperdense material in the right upper quadrant, the region of the pancreatic head. This, of course, is very suggestive of a hematoma, and then we have to understand why is there a hematoma in this patient with pancreatitis, and you really got to think of the complications of pancreatitis. After the patient receives contrast, you can see that there's actually, what this is an aneurysm that's rupturing, and this is of the GDA, and this is acute necrotizing pancreatitis with a complication of a GDA pseudoaneurysm that's rupturing. If you see such a hematoma in the abdomen, it's helpful to do, if the patient is stable, to do further imaging to assess for a potential bleeding source. Here's a patient, this should look familiar at this point, where we see beating in the right renal artery and this aneurysmal dilatation of the left renal artery in a middle-aged female patient. Another patient with similar diagnosis, again, this beaded appearance, and this is classic fibromuscular dysplasia, just emphasizing, again, not just narrowing, but we can see aneurysms from this disease process. So the disappearing vessel, this is actually one of the hardest things to recognize. It may be manifested by sort of abrupt cutoffs, maybe only that you see the signs of ischemia or that there are collaterals present. You may have arterial filling defects or venous thromboses, filling defects that may be bland or tumoral. This is just an example of a patient who had a liver transplant, and there's hepatic arterial thrombosis, and this actually can lead to biliary ischemia in the transplant setting, strictures, sepsis, and graft loss. So just important to recognize that, people see what they are prepared to see. So interestingly, this study by Pochin et al., they tested individuals' ability to recognize what was not on the film. They looked at chest x-rays. So looking at what is not on the film rather than looking for the positive findings. Unfortunately, we don't do so well with that. 60% of observers failed to identify the missing clavicle on chest x-rays when asked, so it's just really important to sort of be aware of what the normal anatomy is and the normal variants that you can more easily recognize when something is missing. So on every case, for example, I always track the vascular, but particularly in the liver, looking at arteries and veins, so that I know that everything that should be there is present. And the only hint may be that there are secondary signs of end organ ischemia. So here's a pretty straightforward case where we have the context of trauma. We see retroperitoneal hematoma. We see the left kidney is not enhancing, and there's abrupt cutoff of the left renal artery. So the left renal artery is missing in this case, and it's due to avulsion from a traumatic injury. This is also evidence on the interventional angiogram. Here's a much harder case. It was missed several times, where it looks like there should be a celiac artery coming off here, and you see what's a ghost of a celiac artery, but it's really filled in with soft tissue, or at least a filling defect. SMA remains patent. The other thing noticing in this case is that the small bowel here is thick-walled, which is sort of suspicious for ischemia, but what's confusing is celiac does not supply this region of the bowel. So you have to kind of keep looking to see what's going on. And if you look at the SMA and SMV, you'll see that there's actually a filling defect within the SMA, and that's the cause of the bowel's abnormal appearance. You'll also notice in the aorta there's a filling defect. So unfortunately, this patient had a thromboembolic phenomenon, probably happening intermittently, and it caused celiac artery occlusion, as well as occlusion of branches of the SMA, leading to ischemia. So this is very important to recognize, and this is a very difficult case. And what's really important here is to note that when you see an area of the bowel that's abnormal, you really need to track the vessels that supply that particular loop of bowel, and you don't want to be sort of, again, satisfactory no search, we see this, this does not match up with supply to this loop of bowel, so we really have to go back and look carefully at our SMA and SMV. Here's an example of a patient who has normal looking SMA and SMV on these images. If you look here, there's a thick-walled abnormal loop of bowel. The patient has pain. We look at the vessels very carefully and we see the SMA is fine, but the SMV is actually filled with thrombus. So again, venous disease or venous thrombus can also cause mesenteric ischemia. So remember, look at your arteries and veins. Here's a case where we see sort of an abnormal enhancement of the liver. On ultrasound, there was a lot of narrowing of the IVC. We see perhaps a little opacification of a portion of the IVC, but the hepatic veins are not filling despite delayed imaging. They should be filling out by this point. If we look on the corresponding angiogram, we see severe narrowing of the IVC and non-opacification of the hepatic veins, and this is a case of Budd-Chiari syndrome. So this also very difficult to make the diagnosis unless you're really thinking about it. The patient underwent shunting. Here's a patient who has absence of visualization of the left portal vein. You may think maybe this is biliary duct dilatation, but if the left portal vein is missing, that has to be considered. And in this case, the etiology is this severe acute cholecystitis, and you can see the thrombus actually extends into the main portal vein as well. So any kind of infectious process or inflammation can lead to a pylophlebitis. In this case, it was acute cholecystitis. Most commonly, we see this as a consequence of diverticulitis. So whenever you have a bowel inflammation, any bowel inflammation, please do look at the vessels because you may see some thrombophlebitis associated with it. Portal vein thrombosis is important to recognize. As we just discussed, it can be a bland, non-enhancing thrombus or tumoral thrombus in the context of these malignancies. Here's a cirrhotic patient who has filling defects within the right portal vein branches and in the main portal vein. There are actual collaterals present, and this is bland thrombus within the cirrhotic patient. While portal vein thrombosis is rare in the general population, there is a higher incidence in cirrhotic patients. And even if it's asymptomatic or it's non-occlusive, it really increases morbidity and mortality. And treatment is warranted to the patient, particularly if they're a potential transplant candidate, to keep them within the transplant candidacy. Here's another example of a patient who has cirrhosis and portal hypertension manifested by splenomegaly. If you notice, the IVC there's a high flow in the IVC and aorta, and there's really flow voids on this T2 weighted image. So the portal vein too should have flow voids, although slow flow may, especially in a cirrhotic liver, may lead to high signal within the portal vein, but it certainly shouldn't be low signal or expanded like this. And so this is more subtle, but when we go to the contrast enhanced images, you see that the left portal vein is expanded with enhancing soft tissue, unlike the bland thrombus we saw before, and this is associated with a hepatocellular carcinoma. So this is HCC extending into the left portal vein. The patient also has bland thrombus within the portosplenic confluence, so we can see both bland and tumoral thrombus in patients. So always look for secondary signs, look at the liver perfusion, look for collaterals. Don't be fooled by early phase imaging where there may be mixture of blood and contrast. And again, these collaterals, they can be so abundant that they can mimic enhancement. So just be wary, and multi-phase imaging may be very helpful in these cases. Here's a case of a renal cell carcinoma, really bad renal cell carcinoma expanding and extending into the right renal vein and IVC. Important to see the extent of this. If it goes into the thorax, then that will change the surgical approach. Again, bland and tumoral thrombus may be seen together. In this case, there's tumoral thrombus not just on the right side, but it's actually extending into the left renal vein as well. As we look further, we can also see that there's bland thrombus behind it along the IVC and iliacs. In this case, just to note, this was not a dedicated MRA or MRV, but because because image quality at this point is pretty good. We get isotropic images and can reconstruct and see all these findings even on a conventional abdomen and pelvis MR. So you really need to be careful and use the images that you have and reconstruct them if you need to appreciate these findings. Here's a really unusual case where a patient presents with embolic phenomenon. They also have this cystic calcified pancreas mass. That's what we were told, as well as ascites. If you notice, it looks like there's, again, this big mass in the region of the pancreas. There looks like there's a filling defect in the SMV portal vein, and so you think maybe this is portal vein thrombosis, but the patient also thankfully had a MRCP. In this heavily T2-weighted image, as we see that this is the bile duct, this is the portal vein, it is high signal, just like the fluid in the ascites and fluid within the cystic lesion in the region of the pancreas. What we're seeing is actually a communication between the portal venous system and the pseudocysts, and this is a complication of pancreatitis. This is not thrombus and should not be anticoagulated, and you don't really want to fall down that hole, but this is thankfully very rare. This is a pancreatic portal fistula, and where pancreatic, the theory is that pancreatic enzymes leak from an injured duct and erodes into the portal vein. And you really want to avoid anticoagulation in these patients. So we move into the category of ulceration and dissection, and really we think about this in terms of acute aortic syndrome, and there's several, and we really sort of several kind of scenarios that we see. There's the classic dissection, the intramural hematoma. We don't often see a tear, but it's most likely due to a tear into the through the intima, but there is an entry tear without an exit tear as opposed to the classic dissection. There's sometimes you can get an intimal tear, which is very subtle on the ascending aorta with no hematoma. Penetrating atherosclerotic ulcer, which is in older patients with atherosclerosis, clearly. These can actually lead eventually to dissections and aneurysms. Then there's the traumatic dissection. In the setting of intramural hematoma, later you may see ulcer-like projections, and this actually has a poorer prognosis. You also might see intramural blood pools, which are considered, which are sort of these little islands of little pools of blood not connected to the intima, and these are thought to represent little avulsions of the intercostals, for example, and do not carry increased risk of dissection or complication. Important to differentiate those things that really dissect into the media, or when there's entities where there's intermedial flap, and there's actually damage into the wall of the aorta versus things that remain within the intima, such as interluminal thrombus, plaque, or ulcerated plaque. They have very different courses of complication. So just to show examples of all the things we've talked about, this is an example of an older patient with atherosclerosis and a penetrating atherosclerotic ulcer. This is a patient with an intramural hematoma. This is best seen in the non-contrast images. You see the high density, the crescentic high density around the aorta. This particular patient had some atherosclerosis, but sometimes this can be seen even without atherosclerosis. You may or may not see underlying irregularity in the wall. This is dissection of what we've seen, and this is actually, more importantly, this is retroperitoneal hematoma, irregular margins of the aorta. This is rupture, an impending rupture, and this, regardless of whatever you want to call it, this needs to go to the OR immediately if the patient is still living on your table. This is again atheromas and plaque. These are not of really urgent concern. You can get ulceration of plaque, but again, you haven't really delved beyond the intima. You can get mural thrombus seen within aneurysms. That is not uncommon. Ulcer-like projections that may be seen as a consequence of intramural hematoma, and again, these have a more poor prognostic indication where it could lead to dissection or a rupture. These are the intramural blood pools, which are considered less serious finding. Just as a reminder, What you really want to do for dissections in intramural hematoma is very important. You recognize that there's a flap or recognize that there's intramural hematoma. Then you really want to classify it as type A, involving the ascending to the brachiocephalic artery, type B, or some sort of in-between type B with some arch involvement. That's very important. That's the most important thing that will help them decide whether there's what the management should be and how urgent it is to intervene. You really want to describe the false and true lumen. You want to understand whether it's patent or thrombosed, and you don't want to, just because you're in the arterial phase and you don't see flow in the false lumen, you don't want to say that is clearly thrombosed, because if you do, there's very different prognosis. So you may need delayed imaging to see if the false lumen is thrombosed, truly thrombosed. You also want to look at the branch vessels. Again, look for end-organ ischemia, which may be caused by the flap itself or by dissection into a branch vessel. Again, most importantly, look for complications such as rupture and ischemia. For intramural hematoma, the distribution, again, is very important. The size of the aorta, thickness of the intramural hematoma, and ulcer-like projections are more prognostic indicators when it's very thick or there's ulcer-like projections, as some of these can lead to aortic dissections and other complications. Moving on to the leaky pipe, when there's extravasation, we can see this clearly in this trauma surgical incidents, as in this patient post-Whipple with a GDA injury. But we also can see in the setting of GI bleed in this patient who has a bleeding diverticulum. And this is actually rising from a branch off the SMA, and we were able to really provide a roadmap for the interventional radiologist who went in to treat this, and you can see that a corresponding angiogram in this case with the extravasation of contrast prior to treatment. Endographs, also you can get endo leaks. Most commonly we see type 2 endo leak, but I just wanted to show you a type 3 endo leak when there is actually loss of integrity of the endograft, and here's their separation of the modular components, a breakage in the struts, leading to a leak in the mid portion of the sac. And is actually even luminal narrowing, where there is injury to the endograft. Here we have a type 1A endo leak, where you have extravasation into the aneurysm sac at the attachment site, at the superior attachment site, due to separation of the graft from the wall. And this might be due to increasing growth of the aneurysm, or in this case, probably due to the severe angulation. And these both are very important to recognize, as opposed to a type 2 endo leak, as these require intervention more urgently. And the type 2 endo leak may not require intervention unless the sac is getting increased in size. So now we move on finally to tangles. These are just examples of shunts and fistulae. They may very well be man-made, so you kind of want to know that, or look at the structure of it to understand that it's a man-made shunt. We see rec shunts from the SMV to left portal vein, mesocaval shunts for SMV to IVC to treat things such as portal hypertension. We often see other shunting like splenorenal shunting and varices from portal hypertension. Sometimes we also see, as in this case, the collaterals that kind of are so abundant that they cause extrinsic mass effect on structures such as the bile duct. So this is a case where there's sort of a cutoff, or at least a narrowing of the common bile duct. You may think that this could be a mass, but when you look at the other data, you look at the dynamic contrast enhanced images, you can see that the biliary duct dilatation is due to compression from these abundant portal venous collaterals. So this is known as a portal biliopathy, where you can get some abnormality of your bilirubin and alk phos due to biliary stasis, but it's rarely symptomatic. Here's an example of a patient who had a partial nephrectomy but is developing hematuria, even though it was a remote partial nephrectomy. And you can see on this angiogram that there's this MR angiogram that there's early opacification of the IVC, and this is just an example of a fistula. Arterial venous fistula as a complication of the nephrectomy. Sometimes we incidentally see angiodysplasia in the cecum, or maybe a source of bleeding in a patient with acute GI bleed. You can see enlarged artery and fast filling, draining vein. And this sort of leads to vascular anomalies. I won't spend much time on this. I recommend to understand the classification system. The International Society for Vascular Anomalies is a helpful site to better read about this. But most importantly, our role is one, to differentiate between high flow and low flow vascular malformations, and look for any other associated findings that may suggest a syndrome, as well as to differentiate between a vascular anomaly and a vascular tumor. So here's a patient who has a mass-like appearance of the left kidney, a patient without contrast. If you look lower down, you see that the left renal vein is also huge. So at first you think, could this be a renal cell carcinoma with invasion of the renal vein? But thankfully, we have contrast-enhanced imaging, which can show that this is actually a giant arterial venous malformation, high-flow vascular malformation, and there's no evidence of a tumor in this case. There's another high-flow vascular malformation of the mesentery. And just wanted to show some dynamic imaging to demonstrate how helpful that can be, differentiating between high and low flow lesions in this patient who has absence of the left deep venous system and all these collaterals as a consequence of Klippel-Trenaunay. So again, particularly in these cases, having these dynamic images are really, really crucial to help aid in diagnosis. So in sum, I just really want you to always look at the vasculature, consider the anatomic variants, and report them, as they do have implications for treatment. Really the hardest thing to see is what's missing, so really familiarize yourself with common anatomy. And also always track the vessels, particularly in high-risk patients. 3D visualization is key to really making a diagnosis in some cases, and also to make appropriate measurements and to assess for more subtle findings. You can get faked out, however, so you want to make sure you don't, you use your window levels and use your post-processing accordingly. And so again, even though the study may not be a dedicated angiographic study, you often can still make a diagnosis or suggest a diagnosis and then recommend dedicated imaging, which is particularly helpful when you have small vessels or vasculitis, or you need to see the flow dynamics or some kind of communication that you really want to differentiate between high flow and low flow states. Thank you so much for your attention. I appreciate it.